Hello everyone, my name is Carl Germann, and today I'd like to briefly review the concept of competency-based education, what it is, how we assess it, and what errors we may make as we assess competency. Some of you will be more familiar with these concepts. Our objectives today are to review the development of competency-based medical education, define competency and the key characteristics of CBME, and to take a look at the methods of competency assessment, the strategies, and the barriers we face when trying to assess competency. This is an interesting time to be involved in medical education as we've had a recent paradigm shift. These pictures of a cobbler and a blacksmith reflect the old apprenticeship style of teaching and learning. In medicine, like any other skilled profession, a learner worked under someone who knew the craft really well and gradually work became more independent. The literature terms this the master-apprenticeship relationship of learning. We have recently transitioned from a traditional model. This model was largely teacher-driven and focused on content and curriculum rather than the learner or health system. With competency-based medical education, or CBME, the competencies and outcomes that are needed by our patient population are driving the curriculum. And optimally, the curriculum and assessment become a continuous feedback loop. So a few key concepts regarding CBME. Graduation ideally would be based upon achieving competency, with time being a resource for learning, not the criteria for progression. And this makes sense as we really care about acquiring competence, not just working and waiting until the training is over. In fact, some medical schools are now graduating students earlier than that 4-year mark. And then, as mentioned, competencies should be derived from the needs of our patients and our healthcare systems. One of the strengths of this framework is that medical competence, more than ever, explicitly includes things like communication, collaboration, professionalism. The 6 ACGME core competencies are shown here on the left: patient care, medical knowledge, communication, professionalism, systems-based practice, and practice-based learning and improvement. So we can take all of the different assessments that we have shown at the top and map them to our predefined competencies. The ACGME does require programs to know what type of evaluations they're using for each of these competencies. All right, let's switch gears for a moment and think about entrustment. When do you entrust someone to do something on their own? What determines this threshold, and how do we reliably determine this? The example I'll use is a driver's license. When and why do we trust a 16-year-old to operate a vehicle at 60 miles per hour? How do we determine their competence? Like driving, this is on a continuum of development of knowledge, skills, and attitudes. Let's look at this from a GME lens. So we now have a scale used by the milestone stages. We have defined levels. When looking at the milestones for residents, in general, level 1 and 2, the physician in training should be under full supervision. And for certain situations, i.e. procedures, they may need to even observe or assist. Level 3, supervision could be available potentially within minutes or on demand. And then level 4, this is the threshold. This is getting your driver's license. Level 5 is becoming a supervisor of learners, so this can be aspirational for a resident physician, or when a senior resident or chief resident are ready to supervise more junior learners. We can apply a threshold to a learning curve, which shows the relationship between learning effort and achievement. So this is how people usually develop skills, even in different fields, such as music or sport. It takes a long time to attain the top performance, but that's not really what we're focused on. You see this rapid increase initially, like getting behind the wheel and starting to drive. Many studies show a similar graph, similar morphology of this curve, whether it be surgical trainees, internal medicine physicians, anesthesiologists, or learning to play the violin. If we insert the Dreyfus and Dreyfus stages of skill development, here's where we would consider training to be ending. Here's where we would trust somebody to work unsupervised. Of course, you would continue, hopefully, to improve and develop skills beyond this point. Here again is this important distinction between traditional medical education and CBME. In the traditional model of training, time, or the x-axis, is the threshold. Now competence, or the y-axis, is the threshold to practice independently. And once the individual is practicing independently, they enter into a deliberative professional practice, we hope. This is continued experiential education. This is your CME or faculty development. I stopped playing the violin at age 18, and I can tell you my curve did not increase, it flattened and then dropped. So let's compare 4 different learners, and let's think about a competency such as history and physical exam skills. So not all start from the same point. They're all starting with different levels of skill and experience, and likewise, not all finish at the same point. So when comparing their learning curves, the entrustment threshold may be different. This entrustment for various skills is not always easy to pin down or even to agree upon as assessors, and studies have demonstrated this. For example, one study suggested that there are vast differences among anesthesiologists regarding when residents were felt to be able to carry out critical procedures unsupervised. The literature suggests that there are 5 basic factors that together determine this entrustment decision: the trainee, the supervisor, the context, which is the environment, the task, and the relationship between the supervisor and the trainee. So how do we, as the supervisors and teachers, reliably judge competence? How do we trust the validity of our assessments? What unintended mistakes might we make? Here are 2 common reasons for inaccurate assessment or low inter-rater reliability: variable frames of reference and cognitive limitations. First, we each may have different frames of reference, and there's a few different examples of this. So here are some common types of rating biases or rating errors that may occur. Inference, an example of inference is a student or resident that is very confident, very articulate in their presentation. They seem to really know what's going on, but this may not transfer into actual knowledge or skill. The halo effect is when we generalize a positive trait to all traits and pay less attention to the negatives. For example, she is such a compassionate and caring resident, and then this sentiment spills over into ratings of other characteristics or skills. Horn is the opposite. This is another form of anchoring. For example, perhaps the resident did something very poorly as an intern and you just can't get past that. Leniency and stringency effect. An example of this would be assessing a learner who is taking care of a patient with a sore throat versus a stroke patient. We may grade tougher in one of these situations versus the other, even though both are important skills. Or perhaps you just had a case of a missed PE. You're going to be pretty stringent around that. And then lastly, central tendency. This is the tendency of managers to rate many employees as just average. We see this in the milestones as well. Well, we don't really have data. You're somewhere in the middle. Medical education, both in medical school and residency, have moved to a more criterion-based rating system and away from rating scales, although you still may see them. Our various rating scales often exemplify the biases I just mentioned. Some of the problems with rating scales: studies suggest that faculty, despite best efforts, use them normatively. That is, they define satisfactory as what the learner at that level would be expected to do. And the problem is, we as faculty have different opinions about this, and we also tend to compare learners to their peers, which is normative rather than criteria-based. We also know that many faculty use themselves as the benchmark for satisfactory, and you can imagine why that may be problematic if everyone is setting the bar or gold standard at different levels. And lastly, many faculty cannot articulate what drives their assessment. They just have a gut feeling or gestalt about it. It actually turns out that it is uncommon for assessors to explicitly apply criterion reference, when assessing learners. I mentioned that one reason inter-rater agreement is low is because raters have different expectations about what is acceptable clinical performance, that our own clinical skills relate to how we rate trainees. And I found this interesting. For example, faculty with more complete history taking and higher patient satisfaction, as assessed by an SP, provide more stringent ratings of their learners. Raters have different expectations about what is acceptable clinical performance, cognitive bias. And true for the opposite. A rater might say to themselves, well, I couldn't do it any better than that. A couple potential solutions for variable frames of reference, biases, inference. We need faculty development to address these issues. And this can be simply challenging the assessor. What was the basis of your judgment? With faculty training, we can hopefully promote a shared mental model and understand the grading criteria collectively. And it should be stated that the best methods for how to do this aren't really known. The current thinking is that faculty development and assessment should occur more as a slow drip, where there's multiple brief interventions as opposed to less frequent boluses, and I think this makes sense. Challenge faculty and ourselves to use the criteria or metrics as accurately described. Use some metacognition here to think about how we think. Am I using the criteria, or am I actually comparing the learner to something else? Another possible solution is to increase the data points, and this can triangulate assessment with the belief that the truth is somewhere in the middle. Another source of assessment error that I'll mention today is cognitive limitations. With cognitive load, we're talking about selective attention. As you know, caring for multiple patients, it's a dynamic environment. You may have multiple conversations or interruptions. You can't do everything all at once. A focused checklist can be helpful here. It's better if it's standardized, not too long, and reused to provide longitudinal observations over time, perhaps targeting certain competencies. It also allows you to become more familiar with them. In terms of cognitive load, another potential solution is snapshots. What this means is not attempting to assess all the milestones all at once, but choose 2 or 3 specific competencies to focus on that day or that encounter. This can work well in simulated events as well, targeting specific competencies. And lastly, you can certainly involve the learner in this. Observation and evaluation don't need to be through a one-way mirror. You can ask questions like, what are you working on? Or what do you want feedback about? And if they're unsure, you could simply ask, who was your most challenging patient today and why? So to summarize, competency-based medical education focuses on the needs of our patients and links our curriculum to these outcomes. It does require numerous observations to provide formative feedback around this knowledge application. Know your assessment tools and the pitfalls of competency assessment. Keep your faculty informed and honest. Make sure they know the scale and the criteria for accurate assessment. This commonly requires some intermittent faculty training and reminders.